Ladies and gentlemen, welcome to Reform Niger Television. My name is Deji Esufu, and I'm really glad to be here with you. We're coming on live earlier today because our guest teacher, has some engagement at his place in another 2 hours. So we're not coming on for 7, rather, we're doing 7 p.m. Today, we're going to be looking at the subject of air health, the issue of challenges with health care delivery in Nigeria. And the person who is going to speak to us is Dr. MJ Adetola, or Dr. Moturayo Adetola. He's going to be our guest, and he's already in the studio. In a few minutes, I'm going to have him come on. Okay, my name is Deji Esufu. I'm the host of this program for today. And we have, the Providence, Reform Niger Television is brought to you by Providence Reform Baptist Church of Ibadan. Today is Saturday. Tomorrow, by God's grace, we'll be gathering with God's people to worship the risen Christ. And we hope that what we share with you today would also help even in your worship of the sovereign God. Again, I want to say thank you, Dr. Adetola, for coming on again to be our guest. I was telling you before we went live that I have an uncle in Canada, where you are right now, Egbon Muri Yusuf. He regards you as his, anytime you're around, he always loves to listen to you. So we're so happy to have you. And I know that our discussion today is going to be very, very moving and instructive. But before we go, the question basically is this: Dr. Adetola, what do you want to tell us? You have your slides with us, with you there, and very soon you're going to begin to open up. But before we go, I told you already that I'm going to ask you. So you were in Nigeria recently to bury your mother, and what are your perception? What do you think? Besides, before we go to health, what do you think about the country?
I'm an eternal optimist. So the last time I was in Nigeria was 5 years ago. I went for a medical mission, and I saw the same niggling problems. The people Nigerians are lovely people, but that doesn't take away from the perpetual leadership concerns that we've always had. This is not a new problem, but it doesn't seem like we've turned the corner on that. And that's my biggest, I would say that's the biggest observation I made. We're still struggling under the weight of poor leadership. And it's just my prayer that God help us out.
Yes, before we came on live, I was just watching Fisaya Soyombo's escapade with the oil bunkering issue in Port Harcourt, in the Niger Delta. How he was able to show, just from the little things that have been unveiled, that the Nigerian army are in cahoots with the oil bunkering, and that the oil bunkering has continued this long because people in the army are the ones sanctioning and this thing. The same thing with smuggling of goods into Nigeria has continued because the customs themselves are doing it. So I'm sure these are some of the things you observed, but that is not your area of specialty is health. And that is what you want to do with today. So we are so grateful to have you. Very soon, I'm just going to minimize myself and make you this. So this is your slide for today, and you're going to shoot. Over to you, sir.
Thank you so much. Just last night, an egbon of mine who is a bishop in the Anglican diocese in North America sent me this observation because he saw the promo. He says, recently a close relative of mine almost died. Medical malpractice is very costly for victims and their relatives. That's a bishop, a Nigerian who's a bishop here in North America said that. And on the platform I belong to, I saw this news. This young man is a 29-year-old. This is in the public domain. His name is Ejiro Gene Igogori. And I saw this just this morning. This happened last year. This young man was playing soccer. I mean, which Nigerian boy doesn't play soccer?
Yeah.
Electrical engineer in Lagos, and he sustained a meniscal injury. And he was actually beginning to get better, but MRI was done, and it was found out that he needed some arthroscopic surgery to just clean out that particular knee. And it turned out through negligence. This is not me talking now. This is the Nigerian Medical Council. They've looked into the
Same.
matter. They found out that there was gross negligence. And this boy lost his life, 29-year-old. He had a bright future ahead of him. Sometimes it's not even the medical negligence. It is the way that the institutions or the hospitals or the physicians or the health professional, let me put it that way, because it's not just doctors. It's the way we handle it that leaves a very bad taste in the mouth. And we have to, these are the things we want to look at today. It's the Bible.
Doctor.
It's
Dr.
the Bible
Adetola.
yes.
Yes, I apologize so much. Usually I should have written the things I should do just before the program. Before you go into your lecture, I am going to introduce you properly. I'm going to read out our doctor's profile. It's very, very important so that you appreciate what you are getting. All right. Dr. Adetola is a clinician, medical teacher, administrator, and medical association leader since he graduated 35 years ago. He completed his medical training at the Olabisi Onabanjo University in 1990. He began internal medicine training at OSUT and UCH, Ibadan, before proceeding to do training in family medicine at the University of Witwatersrand, Johannesburg in South Africa between 1995 and 1998. In 1994, he was a public relations officer of the Nigerian Medical Association, Oyo State branch, then led by Dr. Isaac Adewale, who was former Minister of Health and still a professor with the University of Ibadan. Dr. Adetola is a past president of the CANPAD. He served on the Diaspora Professional Health Initiative, a collaboration of the Federal Ministry of Health and Nigerian diaspora health professionals to facilitate skill transfer to Nigeria. He was a conference speaker at the NMA yearly conference at Abakaliki in 2019, and also often features on the NTA flagship program, Good Morning Nigeria, as an expert contributor. MJ is a lay preacher and a Diocesan medical advisor of the Anglican Diocese of the Trinity, a missionary outreach of the Anglican Church of Nigeria in North Africa. Dr. Adetola is also a Calvinist by persuasion, and he is also a frequent guest with us on RNTV. So thank you very much for coming on. Over to you now.
Thank you. So thank you for that kind introduction. So I was saying, this is a Christian platform, so every now and then you'll hear me go to scripture. So the Bible says, if the foundation is destroyed, what can the righteous do? Problem is, with our healthcare system, our foundations, if we had a very good one at the beginning, I wasn't there in the 1920s when we had our first medical school in Nigeria, 1926, back in Yaba. And I wasn't there in 1948 when UCH was started. So I wasn't there. But if we had very good grounding in those days, it has gone sour somewhere. And we need to go back to where we missed it and retrace our footsteps and start doing the right thing. And that's what we're going to talk about today, so that hopefully our leadership, especially in the healthcare and really in the nation, can start laying a good foundation and build upon that for not just our primary healthcare, our secondary healthcare, and our tertiary healthcare, because we're doing things topsy-turvy. We're getting it wrong, and we need to start doing the right thing. I don't know why my screen is not working for me.
Yeah, so if you just tap it once, it should go. It might rotate, but if you tap it once, you see at the upper uh, side of that
Okay.
presentation, you can actually,
Okay. There
that's
we
it.
go. Now, how can I make the screen bigger?
No, I'm going to do it. I'm going to do it
You
from
do.
here.
Okay, thank you. Right. So I said let's start with a few scary. So here's my former chairman, with whom I served briefly when I was in Oyo State. So when this was about this news I pulled was from 6 years ago when he was the federal minister of health. He says 30% of Nigerians suffer from mental health. Now, 30% of Nigerians will be something like 65 million Nigerians suffer from mental health. So if 65 million Nigerians suffer from mental health, that doesn't mean the kind of people, the variety you see at Yaba, psychiatric hospital or at Aru. Sometimes it's just things like anxiety or depression, mild depression or severe depression or whatever. The question is, do we even have physicians and nurses to take care, to diagnose, to prescribe and follow up these people? We have, at this point in time, we had about 150 psychiatrists across Nigeria, according to him, not me, according to Professor Adewale, 150 psychiatrists. In this city where I live right now, we have only about 250,000 people living in this city. 250,000. Nigeria has 250 million people. And yet, in this city where I live, there are about 20 psychiatrists. More than half of them are Nigerians. Yet, in the whole of Nigeria, there are 150. 150 psychiatrists is not even enough for the city of Lagos. And yet, that's all we have for the whole of Nigeria. There's a state in Nigeria called Zamfara. Again, I'm talking 2018, with 24 government hospitals, but only 23 doctors. How do they manage that? This was how bad things were in 2018. I'm hoping things are better, but that's just a hope against hope. When about 90,000 doctors are on the register in the Nigerian Medical Council, and about 2/3 out of that have actually left the country. And this is reality, and something is not right. I'm just giving you the bad news, okay? More bad news. Life expectancy in Nigeria is about 53 and a half years. That's the life expectancy. Now, people, when I say this, people say, I know some old man or some old woman in the village and they live till 80. I say, yeah, you're going to get the old man, the odd old man who lives till 80 years. But how many of those old men actually live till that age? That's the way we calculate these things. People in Ghana will live 10 years more, 63.9. South Africa, 61. In Canada, the average life expectancy is 81. Infant mortality, about 55 of 1,000 live births will die before they reach 1 year. 55 out of 1,000. In Ghana, only about 30 children will die before they reach the age of 1. That's 30 out of 1,000. In South Africa, 23 will die before they reach 23 out of 1,000 children will die before the age of 1. In Canada, less than 4 will die less than 4 out of 1,000 will die before they reach the age of 4. Now, again, it doesn't matter what they die from, infection, accident, injury, they fell from the staircase or whatever. But look at that number. That's a very high number. Again, just tells us these are healthcare indices that we're doing a lot of things that are wrong. Look at pregnant women. For every 100,000 women that carry a pregnancy, over 1,000 will die in Nigeria. And I'm talking 2020 figures. Over 1,000 out of 100,000 pregnant women will die in Nigeria. In South Africa, 127. In Canada, only 11. Again, it doesn't matter. They didn't necessarily die in the course of labor. We're talking about dying from whatever cause, road accident, because they were beaten up by their boyfriend, during labor, whatever. But 1,000 is a very high number. Again, we are doing something wrong. I threw in the asthma figures there. We're doing a very poor job of managing asthma. These are just to be representative of how wrongly we're doing things across the board. 8,000 asthma patients will die in a year. Ghana is doing poorly there because if you look at their number, I think there are only about 30 million Ghanaians. They're losing about 2,000. And we are about 7, 8 times bigger than Ghana. So about 2,000 Ghanaians will die. Yeah, died in 2020. Canada, 250. So a lot of things are being done wrongly, but let's move forward. So some of the things that have been attributed to why we're doing poorly, brain drain, poor remuneration, obsolete infrastructure, inadequate medical facilities, underfunding of hospitals. But if you look at the top causes of death in Nigeria, there are things like malaria, pneumonia, HIV and AIDS, especially in children, diarrheal diseases. Nigerians are terrible drivers, but our roads are also horrible, protein energy malnutrition, kwashiorkor, cancers. We have terrible cancer management culture. We don't have enough specialists in the cancer care. Meningitis, stroke, tuberculosis, these things are still killing us. I remember back in I entered medical school exactly 40 years ago. And my professor of community medicine, Professor Alausa, drummed it into us that we had a book that we used then, written by Professor Adetola Lucas. It was, at that time, there was this big declaration that WHO and UNICEF did. They call it the Alma Ata Declaration. It was going to be held for all by the year 2000. Year 2000 was a long time away. And the whole idea was, this was the year, it was a set year that we were going to achieve health for all. It was, it was a proposition that every nation should work towards, and the whole idea was primary health care was achievable. Primary health care is defined as the place where every person in each nation should be the first level of contact. So whether it was your primary care doctor or the clinic where you went to receive your health care, it's recognized that health was a fundamental human right. And it's, emphasized community participation. But the point I'm trying to make is this. All of these things I've listed here, if you look at it, they are things that you should be able to achieve, maybe outside of road traffic accidents and maybe cancer care. There are things that we should be able to treat in the primary health care. I mean, malaria, pneumonia, diarrhea, meningitis, tuberculosis. Those things, they should, 80, 90% of the time should be treatable at the level of the primary care. You shouldn't need to go to UCH or LUTH or UNTH or ABUTH to go for treatment there. Your primary care doctor or the nurse who is in charge of those places should be able to take care of it. But what do we see in Nigeria? Somebody has malaria, and what did they do? They go to LUTH. They go to UNTH. They go and line up there. So the primary care is really absent. The general hospital, which form, the general hospital system, which should be the secondary care, they are not really existent. You go there, they are ghost country. That is why a state like Zamfara has 24 hospitals, but only 23 doctors, because they do not exist. Those 23 doctors they are probably in their own clinic, running it, and they're just getting a salary. The primary health care clinics don't exist. Some of them don't have roofs. They're not supposed to have sophisticated equipment. They're supposed to have, this blood pressure machine, needles, syringes, maybe be able to check your blood sugar. But they don't even have those basic things. They've been stripped bare. When they used to have doctors and nurses, when those doctors and nurses retired or left, they were never replaced. And so people are left to their own to find out whatever they could do about their own. And that is why 69% of healthcare funding in Nigeria, almost 70%, is left to the individual. And our people are already poor, and they have to already eking out, a living, are responsible for their own healthcare. And that is why we have such terrible figures as a life expectancy of 53 years. Things are horrible. And then they are left to all this substandard care. Everybody creates their own hospital after 1 year of internship, and they call it a specialist care. And because people can't afford it, they go to the Alpha, they go to people calling themselves apostles and prophets and drinking holy water, holy oil, holy whatever. And people are just dying, like Christmas chickens all over the place. God help us. So, now please help me magnify this. This is very important. We cannot rediscover the wheel. This was a study that was done back in 1961 by scientists in the United Kingdom and America. It's about prevalence of illness and the utilization of medical resources among adults. This is in a population of about 1,000 adults. Sorry about the quality of the picture, but there is a better one, next one, but I prefer this one for a particular reason, because this was the original study. The next one I will show was done only about 20 years ago, but it essentially just validates this one. But let's look at it for a second. So in an adult population of about 1,000, in any month, about 750 of them will have one health complaint or the other. It's a headache, it's a fever, it's a cough, it's a cold, it's whatever. But only about 250, that is about 1 out of 4, about 25% will go and seek help. They go to a clinic, they go to a doctor or whatever. They will go and consult a physician in any month. So a population of 1,000, 750 will have some health issue, but only 1 in 4, about 250 will actually go to a clinic or go to a doctor to go and complain. Of those 250, about 9 of them will be admitted to a hospital, and only about 5 will be referred to go and see another doctor, and 1 will be transferred to a university teaching hospital. Now, think about it. Let's just pause for a moment. In a population of 1,000, only 1 essentially gets to UCH or to your LUT or to OSUT or to UNTH to ABUTH. But where are we pouring money in Nigeria? We're pouring money into the fancy hospitals, into the UCH, into the UNTH, which are places that are supposed to take care of those very rare cases. Don't get me wrong, I'm not saying we shouldn't equip tertiary care, but the point is a lot of money should be going into where we see the 250. In fact, a lot of our healthcare professional training, whether we're training doctors, nurses, physiotherapists, and pharmacists, a lot of them can be done also at the primary healthcare setting, because those are the places where you actually get the patients. Healthcare professional training is not just about knowledge. We say we are moving stuff, all this nonsense stuff. It's also about skills training. This is where we get all the patients. This is where we teach our students professionalism, how to talk to people, how not to behave as if they are gods over their poor patients who are sick, because this is what is also getting us into problems. We do not know how to talk to our patients. We do not know how to be professional and to involve the patient in the care of their own health. We lord it over them and behave as if we know everything, whereas the patient should be responsible. Our task is to give them the information and to let them decide how they want to proceed in their own health care issues. So, out of these 250 out of 1,000 that are actually sick, only about 1 actually need tertiary care. 250 will be taken care of easily in a primary health care. And that is where we should build. But go to all our primary health care places in Nigeria today. They are in shambles. They don't have staff. It's not just about the infrastructure, because every now and then you're going to see a governor go somewhere and they will say they built one in one local government. And you go there 2-3 weeks later, there is nobody. Even sometimes they have the building, but there is no staff with adequate knowledge to adequately deal with those things. And of course, we're even talking about immunization too. Immunization, not just of the children, but even adults, because there are adult immunization that needs to be done. Your tetanus, your diphtheria, your pertussis, they need to be updated every decade, thereabout. And sometimes, we still get outbreaks, sadly, of things like tetanus, especially in northern Nigeria. We are not taking care of these things. These are the things that make for a healthy population. Hypertension is still a huge deal in Nigeria, and strokes and diabetes is killing our population. Where are the places that these people can go and get their prescriptions and get their monitoring and get all the healthy information done? Now, let's look at the next one. So this was 1961. 20 years ago, they went back to check, and it hasn't changed. They found out that, in that population of 1,000, about 800 still will have symptoms in any 1 month. About 327 will report going to seek medical care. 8 of them will be hospitalized, and less than 1 would actually need to go to an academic medical center, which we'll call our tertiary centers. So things haven't changed in 40 years. Most of the healthcare issues can be well taken care of. I have a medical office where I train both undergraduates and postgraduate students. In my office, I run it with my wife, who's an obstetrician and gynecologist, and she gets both medical students and postgraduate students in the office, and we train both undergraduate and postgraduate students in our office. There are things that they have to do in the office. There are office procedures that they learn and they do, and then there are things that they also do in the tertiary office. But the one thing is this: they don't mill around the dog, like we do back at home in Nigeria. You see one doctor, one patient, and then you see 20 medical students and residents milling around one patient. The way to learn is one-on-one, because we're talking about a competency-based medical education, one-on-one. Let me not dwell too long here. I hope you're getting the idea.
Yeah,
Yeah.
Doctor, please let me bring in our sponsors at this time.
Sure.
You can use the time to grab some water and also prepare for the next distance, because I see you're on the 7th slide. You're almost done, so I quickly want to bring in. So, ladies and gentlemen, I want to thank Dr. Adetola. Our sponsors are Lakim Investment. They have a property at They have a property at Ikorodu, and we want for you to patronize them. So in a moment, I'm going to bring up the advert. Please patronize Lakim Investment. They are the ones that are keeping us in business. We are hoping that in the new year, we're going to have even bigger deal with Lakim Investment, but please patronize them. Thank you. All right, doctor. Before you go further, I want to ask a question, or well, make a comment. That thing you said about medical students milling around a consultant to learn. Recently, I went to a hospital to have my ears flushed because I needed to clear the wax there. And the medical students there were so many in the room. And sometimes you see some of them on their phones. You're wondering, are they getting what this man is saying? But you are telling me now that your place there is one-on-one. It reminded me about the story I learned about how Dr. D.M. Lloyd Jones, in the days of his residency, the early 20s in the Britain or in England, that he was working directly with the senior doctor in England then, family medicine. When he resigned and went into ministry, it was a scandal because people were like, are you out of your mind? You want to become you're going to do pastor. Are you out of your mind? So I just wanted you to comment on that before we go on, sir.
Yeah. So medicine prior to about 1910 was actually an apprenticeship. So there was a report called the Flexner Report, which came on, I think, 1910 or 1915, that focused more on the scientific part. And that was when medicine was moved from an apprenticeship program into the university, because we needed to have the scientific part grounded in. So, but the issue is this: medicine is not just a science. There is the skills part.
Yes.
That is why today what you have is you have the university part and you have the teaching hospital part. But there is no way that you will have 20, 30 students milling around one patient to do flushing, and then those students will learn it. There's a feeling part. That is why, at least abroad, we're still doing things wrongly. You have the one consultant, you'll be flushing and people will be watching. You can watch all you want until you actually put that.
So I suspect that practically when the consultant had done one ear, he might even offer the student to do the second one.
Yeah, but you know what? What we do here is a student will be attached to a doctor and he'll be there for 2 weeks, 3 weeks, 4 weeks, whatever. That student will get to not just see, but do. So a student that has done 1, 2, 3, 4
would have gotten it.
Will get it. It's the feel, it's the doing. Not say exam is now 1 or 2 weeks ago, then they'll be rushing to sign. Sometimes they don't even do that. The doctor will just sign them all right. Okay, I like this one's face. We'll just sign for you. Students have not done IV, but we will just sign them off. It doesn't work like that here. Because you are one-on-one, you can't dodge. You will do it. That's the difference.
All right. So we can continue.
Yeah. So that's one. So that's one. The other thing is the healthcare financing in Nigeria is distributed this way. Out-of-pocket payment is the bulk, meaning the healthcare financing is shifted to the patient. And we already have a nation where practically everybody is poor. The only rich people are the people who are in government and the senior apostles in Nigeria. Okay, so every other person is poor, and so the patients are paying for 69% of healthcare in Nigeria. So it just means that if you are not rich, you cannot get real healthcare. And it's not like just because you pay. I mean, in the example I gave at the beginning of this young man obviously could pay. He paid for MRI and he paid to go to what will probably be the equivalent of a top hospital. And there was still negligence, again, not according to me, according to the Nigerian Medical and Dental Council. And he still lost his life. So that's one. The federal government is really not pitching much. They're only paying for about 12% of healthcare in Nigeria, and the state government only about 8%, local governments really nothing. So healthcare financing needs to be redone. It can still be done this way, but something like the National Health Insurance Scheme needs to come in. So people are already paying in a lopsided manner. But maybe if we shift it in such a way, and I'm coming to that when I start giving solutions. So when people are made to understand that Maybe instead of paying out of pocket every time they are sick, if they're already paying into something ahead of the time, because body no be machine. No, one day you may be healthy right now. It doesn't matter. You think you are praying, you are drinking anointing oil, you are drinking only water. One day, this your machine will start slowing down. And if you go and get sick, and you know very well, like I live in a country where everybody is covered. In Canada, in the US, it's not like that. You know, there are people I know who have been sick, they got cancer, they didn't have health insurance, and now they're in trouble. But in the UK, in Canada, we don't have that kind of problem. If you get sick, you know that you go to the hospital, whether it's MRI or CT scan or oncology treatment or surgery, I don't need to pay a dime. That is covered. You know, it's except one, if God says it's your time, I like chemo, then it's your time. That's okay. You know, or you just need to settle it with God. That's okay. Oh, I'm coming home. All right. But we need to settle this. And people need to understand it very well. Now, the Obasanjo, you know, you blame him all you want. He actually started a healthcare scheme, you know, between 1999 and 2007. And by the time he was leaving, he already had it 8% signed up. And the plan was that 2025 is next year. We will have universal coverage, meaning everybody will be covered. Guess what? The last time I checked, about 6 years ago, we were already down to something like 4 or 5%, not up. We're down. So 2025 is a mirage. It's not going to happen. Now, there are some good news. Many healthcare practitioners in Nigeria and institutions in Nigeria are committing to offering excellent care, including auditing themselves. That's a good thing. So we're not saying everything is bad, but leadership is a problem. And I said that at the very top. Leadership is a problem because if you find some, you know, the right kind of leadership to say, we're going to do this, and they lead in that particular direction. I mean, we once had a gentleman called Professor Olikoye Ransom Kuti, who was really gone ho on this primary healthcare business under a leadership that was very corrupt. I mean, and I'm talking of IBB. IBB was corrupt, but Olikoye, he had direction under this. But since Olikoye, we really haven't had a lot of people with spine who really wanted to take the bull by the horn and go in this direction. We have some Nigerian practitioners in diaspora who are returning to try and fill some of the skills gap. But it's a tiny drop in the ocean of needs. The temperature where I live dropped to about minus 37 with wind chill 2 days ago. It would be nice to be back home in a warm country. You know, people would like to come back and contribute and share their skills and all of that, because things have stagnated in our country. That's the reality. Things have really stagnated. You know, we can deceive ourselves. We call our hospital centers of excellence and all that kind of stuff. The truth of the matter is, many of the stuff we have are outdated, outmoded. Our curriculum have stagnated in lots of places. And I'm not just talking medicine now. It doesn't matter whether it's nursing or pharmacy or physiotherapy. That's the reality. We can keep fooling ourselves and say also call ourselves all sort of fantastic names. That doesn't take away from the reality that things are not where they're supposed to be. Healthcare advocacy groups are beginning to appear in Nigeria too. Just this week, I learned about two, you know, in Abuja, who are saying, you know what, you guys have done wrong, and they're going to go to court and take us to court. So those of us in the healthcare professions in Nigeria, we are better start getting very careful about what we do, how we talk to people, how we manage them, and when we mess up, we own up and talk to them instead of just pretending that we know everything. We are not Mr. Know-it-all. So this next slide I'm going to is where I talk about a few things that we need to do. It's just one slide, but I'm going to dwell there. So we need to make investments in primary healthcare as a matter of priority. Remember in that slide that I showed earlier on about the prevalence of illness and utilization of medical resources among adults. In a population of about 1,000, about 250 in any month will have some healthcare concern. sorry, about 750, that's about 3/4 of the population will have a healthcare concern, but only about 250 of those, that's about 1/3 of those who actually have a healthcare concern will go and seek healthcare. And most of those healthcare needs will be taken care of in a primary healthcare. They don't need to go to a teaching hospital. In any case, if they need to even go to a teaching hospital, which will be only about one in a population of 1,000 or one out of 250 that actually sought help, they actually should need to be referred. So there should be a proper referral system. So the doctor in the primary healthcare or the healthcare giver will need to write a letter. And not only does he write a letter, when the doctor in the teaching hospital sees, he should write a letter back so that there is a chain of custody, chain of care. That's the way things are done. And yes, we need to build a secondary and tertiary healthcare system, but the people who actually need the cares at the secondary and tertiary care are people who actually are very sick. Like I said earlier on, people with cancers, people with severe injuries like road traffic, road traffic injuries, and that's weird. And that is why things like providing good water system, providing good roads is also part of healthcare. So if our roads are good, like I traveled on the Shagamu Benin Expressway, geez, that's the worst road on planet Earth. And I'm not trying to be hyperbolic here. I don't know how,
I
and that's
had to
called an
come up
express.
here.
That is called an expressway. At least
Doctor,
eh?
I'm sorry to interrupt you. I had to come up here. When I was doing training in Egbe, my trainer, Pastor Nick Kennicott, said
Yeah.
that when he was serving in the military, they were sent to Iraq
Yes.
to fight war. He said that the roads in Iraq and many war-torn countries are better than the roads in Nigeria. When I heard that, I just gave up. I said, Olobata.
I'm telling you,
Over to
now
you, sir.
some of my friends here said, "Oh, the Lagos Ibadan Expressway has been done. It's so good. Is this one?" I say, "Okay." So when I was traveling somewhere between Bega, they used the concrete to cordon off certain parts. I said, but they said they just finished this road now. Some of those part of that road had become one lane. They said it's because it's a flood damaged that part, so they are working on it. Number one, I didn't see any repair crew, and then I went on the internet. I found out that this has been going on for over a year. I'm like, this is the premier road in this country. Premier. They've cordoned out that part off for over a year. There are no repair crews on site. What at night? What if somebody is driving and didn't know? They can drive into that concrete dividing the road and they can lose their life. What are we doing here? This is also health care. Anyway, so there needs to be a lot of investment in our primary health care. It is said that Nigerians are spending $2 to $3 billion every year abroad to seek healthcare. If we can use a fraction, even if it is only 10% or 20% of that amount to develop our own primary healthcare, I mean, and that just means 200 to 300 million dollars every year, and invest that in primary healthcare. And when I say invest, I'm not just talking the building, buying syringes, buying a blood pressure machine and blood sugar testing and maybe minimal laboratory. But it's also about developing the human resource, because that's very important. Now, when you don't train doctors and nurses in 1 year, those things take time. But you know what? Even abroad, in the US, in Canada, in the UK, they have what we call nurse practitioners. They have physician assistants. We can train some of these people within 2 years and at a high level. It's intensive. It's for the brave, but it's doable. And these people can form not just an intermediate resource, but they can last. And this is actually something I think we can do. So the government needs to actually get into this and decide to train nurses who are interested, as well as even create physician assistants. It's minimum 2 years, but they can be very good and they can fill these gaps adequately. They will be consulting. They are not going to be allowed to do surgeries and stuff, but they will be able to take care of malaria, blood pressure, taking care of diabetes, treating pneumonia. They will be able to prescribe. But part of that also is, we have to get rid of all these people who are selling fake drugs. The kind of thing that Mrs. Dora Konyili was doing. Because there's no use. You see a doctor, you see a nurse practitioner, you see a physician assistant, and they give you a prescription. And then you go to the drugstore or chemist or pharmacy and you buy fake drugs and then you still die. That's not going to work. And there's a lot of that in Nigeria. So we need to fix that. So we need somebody who's going to be as aggressive as that lady. That lady, God bless her soul, may her soul rest in peace. She was awesome. And we need men and women who are going to be committed to the kind of thing that she was doing during her time on planet Earth. Okay, she needs to be centered, by the way. Now, secondly, we need a universal, maybe I put it in brackets, compulsory health insurance. Like I said earlier on, people are already paying 69% of healthcare costs in Nigeria. 69%. So if we make it compulsory and people are actually paying, and unlike the last time when Obasanjo did it was only the federal government that was putting money into that purse. This time around, it has to be made compulsory. The state government must pay its own share. The local government must pay its own share, and every Nigerian, it has to be part of the tax. It must go into that purse, and every Nigerian. Now we have all this NIN, we have BVN, we have all these things that they keep bringing up every time. So the point is, we have a database, or we should have a database of every Nigerian, and people should be able to bring it up when they go to the hospital. It shouldn't be difficult. We should know everybody who is a Nigerian and who's not a Nigerian. And already, I don't think a lot of people are actually migrating to become Nigerians at this point in time. So that allows us to know who a Nigerian is. And when you're sick, if we contribute into this pool to start taking care of everyone, it allows us to get a pool of money to build our infrastructure, to remunerate our healthcare workers, and to take care of our people. That's the way to start. And well known and noted, trustworthy people to be put in charge of this thing to build our healthcare insurance corporation. Let's put it that way. This is the way to build, because right now the poor are suffering under a heavy weight. That's why people are going to all these fake people and faith healers, and it doesn't matter whether they are Christian faith healers or Muslim faith healers or the Sheshe faith healers. We're paying a healthy toll. That's why our life expectancy is very poor. That's why the children are dying. That's why pregnant women are dying, because when they go to the hospital, they can't afford to pay. So healthcare insurance is very important, and it must be universal. Everybody must be covered. It shouldn't just be for government workers or for people who are working in some industry. And the industries must be made to also pay into that, because they are mining all the things that the government has given us, that God has given us rather. So they must pay into it. The government must pay. Even churches must pay, and mosques must pay too. Everybody must pay and take, so that our people can be taken care of. We must overhaul our healthcare professions education. The UCH was created in 1948, and the second generation teaching hospitals, Lutz was the second one created, I think, by Elliott Commission. And then these provincial teaching hospitals, ABUTH, UNTH, and the University of Ife, now Obafemi Awolowo University, they came after. They were essentially this, I don't know, the second generation or the second and a half generation. And then the state hospitals, the state university teaching hospitals, the Bendel State University, the Ogun State, the Ondo State, were the third generation. And then all the other ones came after. But basically what happened was they essentially copied the curriculum of UCH of 1948. But since then, things have moved. Now, I know about a decade ago, UCH, they have tried to update their curriculum. I'm not quite sure if all the other medical schools have done that. If they did, I don't think many of them are really operating it. Let me give you an example. Most of the medical schools, if not all, do not have family medicine, for instance, as in their curriculum in Nigeria. They only have family medicine as postgraduate training. Meanwhile,
Okay, doctor,
everybody else in the world already has family medicine as part of their undergraduate curriculum. Nigeria doesn't.
doctor.
When I was a guest, one of the guest speakers at the NMA, conference in Abakaliki about 5-6 years ago, some of the doctors said, did all these Nigerian doctors that are going to England and going to Canada and going to USA, they are a drain, because even if they return, they are not going to be beneficial to Nigeria, because they don't go and study the real specialties like cardiothoracic surgery and brain surgery. And I opened my mouth like this. Fortunately, I didn't have to respond, because there's this brilliant brain surgeon. He's I can't remember his name. I can only remember he's in Abuja. He trained in Uniben. He was the one that responded and said, "Actually, we are not the ones that are needed. It's the family physicians that are needed." Because
Yeah,
this is the, remember that graph again. Most
yeah,
people, 250 people out of 1,000 will complain. Only 1 or 2 of them will eventually need the tertiary care. Meaning
yeah.
248 people will not need tertiary care. They will be
They'll be
taken
they'll
care
be
of
taken care
at the
of at
primary
the
health
primary
level.
and the secondary.
Exactly. But even our doctors in Nigeria don't get this. So the thing is, if you don't get it, and that's why family medicine is not a priority for them. It's not.
If
We
it,
have less than 1,000 certificates at the National Postgraduate Medical College in Nigeria. It is not a priority. It's not.
so
They don't.
so if we're doing the right thing, sir, Dr. Adetola, if we're doing the right thing, if we have say 1,000 graduates or 1,000 people going into specialty in our hospital, doctors going into specialty, we may have
Yeah.
as much as 500 of them doing family medicine. Is that not
Let me
what you're
give you,
trying to say,
let me
sir?
give you an example. In Canada, where I live, there are about 70,000 registered doctors in this country. And about 36,000 of those are family physicians.
Wow.
And I'm not
Wow.
talking people who've finished house job and started their clinic. These are trained, with postgraduate training.
Yes. So
Trained,
a whole lot of the health issues are taken care of before they go into the tertiary level.
they won't
A
even
whole
get
lot.
there. Yeah, it will have been
Wow.
taken care of. So all your diabetes, hypertension, cold, even most of the time, the diagnosis of the cancers are already done. So after we've
So
diagnosed it, we now send them. We are the gateway. So family physicians are
because
the gateway to your healthcare.
because I'm aware that UCH, by the way, I'm going to get this video over to the chief medical director of UCH,
This is
and
Jesse.
to some.
Jesse.
Yes. Yeah. By
Yeah,
the way,
Jesse and I
I
were
think
in the same cohort. We were in the
Jesse
same cohort in
Otegbayo, right?
UCH. Yeah.
You know him too. Can you share some things about him?
I
Positive.
don't know if you know, I don't know if he knows me. He got into UCH in 93. I got there in 94, but
Okay.
because I had started in Shagamu before I came to UCH.
Okay. So I'm going to get this video over to him, and I'm sure he's going to, and then to some other senior doctors also. So that means that if a lot of these issues are taken care of at the primary and the secondary, I mean, what do they call it? The tertiary people can concentrate on more serious problems, finding solutions to them.
That is what everybody in the world does, except Nigerians.
All right, sir. Let me not interrupt you again. Just continue.
Okay. So that's not, we need to overhaul our healthcare professions training. And again, when I say that, I'm not just talking about doctors, so that my colleagues don't think that I'm trying to focus on them. It's the same for nurses, for physiotherapists, for pharmacists. We should be focused not just on a command of knowledge, but on core competencies that are relevant to Nigerians. So when Professor Adewale said 30% of Nigerians have mental health issues. How many of our Nigerian physicians, for instance, after completing their house job and national service, and they now have the full license, can competently diagnose anxiety, depression, and start them on medication and continue to monitor them without saying, this one, I'm going to send to Arrow, I'm going to send to Yaba, or send to psychiatrist. I'm not talking of those who are frankly psychotic now. I mean, if they're frankly psychotic, I get that. But 65 to 70 million Nigerians have mental health issues. Or how many Nigerian doctors can say, oh, this person needs a regional block to do a repair of an injury in their hand. And so I'm going to do it. But these are the things we should be focusing on, not just on a curriculum that was handed over to us in 1948. We should be focused on things that are relevant to Nigeria and to the Nigerian health sector. So, and then all this unnecessary bickering that we do in Nigeria, only a doctor can become CMD. Only a doctor can, why? And then if you don't have a PhD, every doctor who wants to become a professor must go and get PhD. Why should the doctor get PhD? So these are all silly things that we do. Now, doctors in England and Canada and the US do not need a PhD. They never get a PhD. They get their fellowship and they go on and progress in their academic career to become professors and become whatever they need to. And then I came to Nigeria and they call some people medical scientists. Why? Things get to Nigeria and they become leprous. May God deliver us. I guess there are things I could keep talking and talking about, but I think we need to stop. Here is the point I'm trying to make. Foundations have been destroyed in Nigeria. And if we are going to get things right, if we are going to offer good health care, we have to rebuild our shattered foundations. That's the point I'm trying to make. Part of it is not just about throwing money all the time and without measured results. We have to be able to audit. We have to be able to rejig our healthcare professions education. We have to focus on primary healthcare, just as the World Health Organization and UNICEF determined in Alma-Ata, Kazakhstan in 1978. We need to go back there. We've missed the 2000. We missed the healthcare insurance thing that we set for 2025. We've missed a lot of things. And we need to reorder our priorities. What are the things we consider important? Let me finish on this story. Five or 6 years ago, I was the guest of NMA and in Abuja for the NMA conference. And Professor Lambo was the guest speaker. He was talking about this national health insurance. And he was a former health minister. So, and you could see the man was lamenting. The man was lamenting how we are not taking good care of the health insurance, how we've missed the mark, how things have gone southwards. And the hall was only about 10% filled. Nobody was listening to him. But about 30 minutes into his talk, the vice president was going to arrive. And everybody started paying attention. And then the man came in. He even had his own, and I'm talking Professor Shimbaju here. The man even had his own song. I didn't know that. He has his own entry song. And everybody paid attention. And the man came and talked some things that I can't even remember. Nothing of substance. Don't get me wrong. Professor Shimbaju is a man of substance. But on that occasion, he said nothing of substance. But the man who was actually speaking about our healthcare, about how we can bring it back, how we can rejig it, how we can rebuild the foundation, nobody paid attention to. That is our Nigeria. We don't pay attention to things that are important. We pay attention to things that are of no substance. I hope this gets somewhere. I thank you.
Thank you, Dr. Adetola. Thank you so very much. Thank you. Like I said, I'm going to send this to all the doctors that I know. I pray they will do something. One of the things that I am getting to learn, and those of us who are into apologetics are also discovering this, that people are hearing. Okay, they are hearing and they will eventually take action. Recently, I began to study Obafemi Awolowo, and I'm like, where have I been? I have his book here, Awo, the book he wrote in 1959. just after he concluded his term in office, his 8-year term in office. He gave a record of the things he's done. He wrote in this book, he said that, look, we are not, that's why they call themselves Action Group. He said, we're not going to be talking. We'll allow our works to talk for us. So I'm reading from page 245. Just a little quote here. He said, freedom for all, life more abundant, one of their policies. He said, it is our belief that the people of Western Nigeria in particular, and of Nigeria in general, will have life more abundant when they enjoy 4 things. They pursued 4 things throughout 8 years in office. 4 things. Number 1, freedom from British rule. Number 2, freedom from ignorance. Number 3, freedom from disease. And number 4, freedom from want. Now, to be able to achieve, of course, they achieved that freedom from British rule in 1960. To be able to achieve freedom from ignorance, they pursued free education, where it was the farmers and workers that were being taxed so that they can sponsor young children in school and go to school. Incidentally, a lot of people who enjoyed that free education, many of them are dead now. I don't know, they came and they didn't give our own generation free education, but that's by the way. Then the third one, freedom from disease. They pursued a policy in which from age 0 to age 18, every child will have access to free health. I'm aware of the National Health Insurance Scheme. The person who brought it, his vision was that all Nigerians will have access to free health. But they started it with government workers, but then to extend it. Because the whole idea is this: if you get sick, and you were saying in your presentation that the people who get sick and who can afford healthcare are the rich people. But the truth of the matter is that if you have been putting away a little of your income towards insurance, let's say, for example, you earn 10,000 naira and you put 500 naira every month away for insurance. By the time you get sick, you will access the pool of funds that others have access, put together to be able to cure and to heal, to cure yourself. That was the whole idea behind the health insurance scheme. But up till now, the vision of the person who bought it has not been realized. The insurance is still limited to maybe government workers. And unfortunately, when these government workers retire, when they need the health insurance the most, many of them can't access it. So he said freedom from disease, and finally freedom from want. The sense that everybody, there should be a minimum wage. The Western government then, the Western government which he headed, was providing a minimum wage that was higher than the one that the federal government was providing them. They sought everybody should be gainfully employed. Everybody, everybody must find something to do. But unfortunately, we're where we are. He even said it. He said, look, we can get freedom from British rule, but still be beleaguered with the remaining 3, health, ignorance, and want. And almost 60 years after, we are where we are. So that is that. I have a question here, but there's a comment. I don't know whether it's a question. I want to look at it. We have somebody who, okay, I think he's leaving a comment. Let's look at what he said. Thank you so much for the presentation. The problems are a bit deeper than this. This is from Ni Oguntipe. Thank you, sir, for joining us. What do you have to say about that, sir?
I don't know at
what
point.
My question.
Dr. Ogundipe is an anesthetist and a
okay.
So I don't know at what point he left that. So maybe I don't know whether it was at the end or somewhere at the beginning when we were still talking. I would have loved to have him say more so that I can.
Okay, Dr. Ogundipe, if you're still available, please leave a comment wherever you're reaching us from. I think he's reaching us from. Can't remember where. I don't know where he's from. Facebook. Please leave us a comment and let us know, provide some clarity to your comment. We would really like to shed some light to it. Now, one of the things that led to this program was the video you did, sir, where you were lamenting Nigerians leaving the abroad and then come to Nigeria. because they cannot wait on long queues for surgeries and all of that. So I was wondering what is happening. Why are they having to wait so long for surgery? What's the issue? If you have so many clinicians and all of that, why is all of that happening?
So what happens is especially in places like UK and Canada, what they do is they prioritize certain healthcare. Let me give you an example. So we call it triage. So TRIAGE. That's the word of the day, triage.
Okay. Okay.
So so let me use an example. So someone has prostate enlargement. So you are over 50, a man, you're over 50, you're gonna have some form of enlargement of your prostate, meaning in time when you go to pee, things are going to be slowing down. They're not going to be, and it can be a nuisance. You start waking up 3 times, 4 times, 5 times during the night, and so you have poor sleep, and your urinary stream is not as good. But the bigger problem is, like it's disturbing your sleep. As long as it's not cancer, so the doctors say, okay, we'll put you on the list to do it. Okay, first of all, they'll put you on medication, but for some, medication works just fine, but for some other people, the medication is just not enough. So they say, okay, we'll do surgery. The surgery is, these days we do it through a scope, and the surgery is about 20 minutes or less. But the problem is the waiting time can be long. So you get on the list and you may be waiting 9 months, 1 year, because there are other people on the list. Number one. Number two is the the there are a lot of people ahead, and you have been considered not to be an emergency. You're not
Yes.
going to die from this.
Yes.
So you understand.
Yes. Sir.
So yeah, so it's a nuisance, and yeah. Whereas if it was like cancer, it will be done in like 4 to 6 weeks.
Okay.
Okay, it will be done in 4 to 6 weeks after all the initial investigation have been concluded. But because this is not a cancer, you know, it can be delayed depending on where you are. It could be 6 months, it could be 9 months. So this is the problem. So some of the people will say, I can go to Nigeria and get it done now. So yeah, I'll just pay my money. I mean, you could get to Nigeria and get it since it's your money. You will get it
But
done next week.
sorry, sir, Emma Binu for interrupting you. If these people are aware of the way healthcare is in Nigeria, why do they have to go to Nigeria and get
No,
it
the
done? Why
thing
don't
is,
you just wait the 9 months?
the way it's presented is Doctor So and So has endoscopy. It's the same endoscopy that I'm going to do in England. And this guy,
Oh,
don't forget, not everybody has the same information. It's endoscopy is
yes.
endoscopy. It sounds the same way, but not everybody has all the information. Uh,
Yes.
in all fairness, there are doctors in Nigeria I will have my surgery with. Okay. Uh,
Yes.
for instance, after I made that rant on
Video.
Facebook, I've actually been
Yes.
contacted by some of my colleagues.
Okay.
I've actually been contacted. There's an Egbon of mine in the UK who is OBGYN who contacted me. And then another colleague who's an orthopedic surgeon who trained in the UK, who has moved to Nigeria
Okay.
last year, contacted me and says, well, I decided to be a part of the solution. I'm doing this surgery and all that. So so it's not like there are no competent hands. There are who are doing these things.
Okay.
But the point
These people leave the UK, they leave their places and they come to Nigeria to
yes,
offer
there are
those
people like that. Yeah.
expertise.
Yeah,
Oh,
and
okay. That's good.
and I
That's
also
good.
know, for instance, a family of mine 2-3 years ago had a brain tumor in Abuja,
Mm.
and I wasn't satisfied with the initial person who worked on it because I think this person just had a poor communication problem, didn't do the right thing, or didn't give them the right information. And I sussed around and I found a neurosurgeon, one of these neurosurgeons in Abuja, who did an excellent job. So there are places in Nigeria where you can get things done,
Get.
highly professional, highly skilled people. Question is, you have to be able to do your due diligence to find these things out. you
These
know.
people, yes,
Yes, so
yes,
these are the issues.
just fall
So
into
there
the
are things
wrong
like that.
hands.
Yeah. So people don't want to wait, and they just go, and then they will say, I'll get it done, and then I'll be back in England or Canada and I'll be fine. This is
Mm,
Wala.
Ben, Ben.
So, and then
All
things
right,
like
thank.
knee surgery. Knee surgery here, they put you on the list. You maybe wait because again, you will have pain. But we'll just tell you take Panadol, take Advil or whatever, and then we'll do it. And when we do it here, it's not like oh, you can only go to this hospital or that hospital. All the secondary and tertiary hospitals, you can have your knee surgery done. We don't have
Mm,
dedicated orthopedic hospital like unlike
for that.
Nigeria, where they will say, oh, you go to Igbobi. All the
Uh,
hospitals
uh,
here that are
uh,
secondary tertiary can do it.
you know, criticize. You know, somebody came on your Facebook page the other time, came very hard on you. Say, what is it? I had to, you know, I did the Dada Oleja. Ola buro to gbọ́njú. I came
I
after the
saw that.
person. Àbí ògbádùn. Ẹ̀gbọ́n mi lọ. I
I
was
saw
really
that.
upset, you know, but I mean, we too, we are trying now because my CMD is going to see what, I mean, this thing now, and he's going to say, why you just bringing someone, just criticizing. We are trying, we're doing our best
No,
within
no,
the
no.
resources
I'm
we
also
have.
saying we're trying now. Look, my teaching hospital in Shagamu, I fight for
Right.
them hard. So because I also teach there. So if you
Yes,
come at us, you will meet me as a hard rock of defense. Okay,
yes,
so I defend them, but at the same time, we have to be realistic.
Ben.
At And the point is this: there are things we can do. Sometimes, remember, it is little hinges that open big
Mm.
doors. Sometimes some of the changes we're talking about are not the huge changes, small
Yes,
changes,
yes.
but we're talking about human lives. Once you die, 6 feet new.
Otitan.
So people need to recognize this and make all these tiny changes that we're talking about. Some of these are not very difficult to do.
Yeah. Thank you, Dr. Adetola. Thank you very much. We have gone past 1 hour, and this is about the time we usually round up. Dr. Adetola, I want to put you on the spot, and I should have discussed with you privately. I'm going to put you on the spot to embarrass you, but I'll put you on the spot. The people who brought the gospel to Nigeria, this is a gospel channel, we usually used the health channel. They will come. In fact, I know of some, the husband doctor, the wife nurse. The two of them will team up in a community. They will be offering healthcare to people, and at the same time, they will be, in one way, they will be preaching the gospel. Reform Nigeria Television, we're trying to pursue, maybe in the new year, we're trying to pursue a situation where we can actually allocate one day of the week to different people. Eventually, we want to grow the channel to the point where we're full-time, 24 hours. We want to allocate one day of the week to a topic. The brother who is assisting me has found a topic. That's Oluwa Shogo. Shogo is going to be dealing with, he's going to build a specialty on false teachers. So he's going to go into, just sit with some of these people who are deceiving people in the religious sphere and publish, just take them one after the other. He did one on Chosen recently. Fantastic. I said, look, you have to specialize in that. You know, our Saturday broadcast, we want to deal on theology, doctrine of God, doctrine of Christ, doctrine of scriptures. You know, why don't you look for a day for us? Okay, where you just come and talk to us about medical things. Invite your colleagues. Let them, ONG. You're a family medicine person, so you have a worldview, you're able to see all of them at the same time. You know, this your guy that does short video, that did something that I did a commentary on, one big guy from the East, you know, let them come and talk, you know. But it can be monthly, it can be weekly, depending on your schedule. Please pray about it. I'm not asking you for a response. Just pray about it. Let God lead you. Okay? Because it is very clear. And then as you're doing that, of course, we know that the foundation of sharing this knowledge is the gospel of Jesus Christ. We're so very grateful to have you here. And I know you're just a WhatsApp away. Egbon, I saw you post something on Facebook. Oh yeah, come and talk about it. And I know you'll be available. Thank you so much for coming. We appreciate you. Dr. Adetola is a family medicine physician in Canada, and he has been talking to us about this whole challenge of accessing medical care in Nigeria. If you're just joining us, I want to ask that you start when we end, start the video again and watch. This is very instructive. Please share the video. You may be saving somebody's life by sharing the video. So send it to every medical doctor you know, every nurse you know. When I'm done, I'm going to send it to every medical doctor on my WhatsApp list and every doctor. Okay, and as many people that I think might find it instructive. Okay. Again, Reform Nigeria Television is brought to you by Providence Reformed Baptist Church. Tomorrow we'll be meeting. We meet at the University of Ibadan. If you want to get to know what we do, please send me an email at newdayGX@gmail.com or providencechurchibadan@gmail.com. We want to thank Lakim Investment for making our broadcast possible. Please patronize them. If you're in Nigeria, you need a place to stay, please get in touch. Call the number on that advert and they will do you good. If you want to know more about that, please, you can also get in touch with me through New Day GX. Dr. Adetola, again, I want to say thank you. I hope it won't be too long again before you visit us in Nigeria. Just to say hello. This last time you came, it hurt me so badly. I couldn't see you. I arrived from Port Harcourt from a trip. I landed. I was supposed to see Brother Peter Uka. I sent him a message. He said he's not in the country. I said, okay. So all my mind was built around meeting Peter Uka that morning. So when he said he was not in the country, I just said, I'm going to Ibadan. I could easily have gone to Otta, but I forgot. I forgot completely. You know, that's what paid me, because I could easily have just taken a cab from Baga and head to Otta for your program, but I forgot, you know, until I got home and I was checking Facebook and say, Egbawa Nigeria. You know, so I'm so sorry. I hope very soon you can visit, and then by God's grace, I've told my wife when next you're coming, we'll be seeing you together. Thank you, sir. Thank you very much. Also, thank you for being a blessing to us. Let me embarrass Dr. Adetola. When we started Providence Reformed Baptist Church, when we started, it was Dr. Adetola that sent us 100,000 seed money. Wow, he sent it, you know, and we use that money carefully. So thank you, Egbon. We really appreciate it.